Hello, hello, hello. This is Kenny Perkins, aka your cancer guy. And again, as we always do, we're bringing you another phenomenal guest. And let me tell you, this next guest, he's talking about how he's treating cancer patients, not just with immunotherapy, but not just uh, systemically. No, he's saying he's going directly into the tumor and giving treatments that way. So we're going to learn a lot today about immunotherapy. And our next guest, this physician, he comes in from Beverly Hills, Miami, even does some practicing overseas. So it's going to be a great ride. I hope you guys are ready to take notes. And as I tell you, you're here to All Talk Oncology. And if you guys listen to any of our podcasts, you know that one, I've created so many things for cancer patients. We have a book out, but we also have a program that patients can go through if you first get diagnosed, that it walks you through that whole system. So make sure you hit the link and look into the programs that we've created for you. So again, today, our next phenomenal guest, please allow us to introduce to the stage our next doctor, Jason Williams. Jason, welcome to All Talk Oncology.
Thank you. I appreciate it, Kenny. Good talking to you. Yeah. So, obviously a lot going on in cancer right now. And, it's very interesting. Everybody's looking at immunotherapy. And, we are as well, obviously. And, I think the thing that makes us different is that we also put our immunotherapy into the tumors, which is, a different approach than other people take.
Well, let's talk about that. Immunotherapy is probably one of the newer types of treatments, right? In style, right? There's always been radiation, there's chemo, but now we're talking immunotherapy. Could you talk to our listeners a little bit and give us the history of basically what is immunotherapy so that they understand?
Yeah, well, things, I guess, things really started kicking off like 2014 when the PD-1 inhibitors got approved. You got Keytruda and Opdivo, and these are drugs that block receptors that the immune system, or well, really the cancer is using to turn the immune system off. And so it was the idea that you could allow the immune system to see the cancer. And there was actually, slightly prior to that in 2011, the approval of Yervoy, which was a CTLA-4 inhibitor. And most of that, they were looking at these immunologic cancers, mainly melanoma, assuming that, well, melanoma was the more immunologic cancer. Obviously, it's expanded out now to understand that really any cancer could be immunologic. It's just what combinations, what drugs do you need to use to get that immune system to attack it. But yeah, that's what kind of triggered it all. And if you look at the current standard, I mean, you've got the PD-1 inhibitors, you've got CTLA-4 inhibitors, you've got also LAG-3 combination. Those are your weapons that are FDA approved, and those are drugs that can be used and certainly effective. But one of the things that we've done is, took those drugs and more and injected them into the tumor. It's not just, saying, oh, we're going to give it systemically, but we're going to put it in the tumor, put it where it is. And there were lots of animal studies and other things that supported this, that putting the drugs in the tumor was much more effective than just giving it systemic, because you want to start the immune response at the cancer. And so it's better to put it at the cancer site.
Okay. Well, that's quite a bit of information for sure.
Yeah.
But you're talking about from 2014, and so how did you get involved in kind of evolving into this?
Yeah, well, it goes way back for me. I mean, so originally when I was young, my grandmother had breast cancer, and I watched her go through that. And she passed away. She got diagnosed and lived a couple of years, and I saw all the things that they did. Mastectomy, radiation, chemo, and then I was 12 years old when she died, and I thought, gosh, there's got to be something better than this. I mean, how could that be? And so I really wanted to get into cancer research. So when I got into college, I was interested in medicine, interested in trying to go like a direction for cancer, and was fortunate to get into some research programs where we started doing work, cancer research on mice, doing gene therapies and things like that. And so one of the things that I noticed, and this was when I was only like 20 years old, is that we inject tumors in the mice and we could cure the mice. Um, But then when you see the drugs get developed, what do? They take the drugs and they make it into intravenous form or an oral form. But I was like, it's like, well, that doesn't make any sense because we're injecting in the tumor in the mice. And when I question some people, are like, well, it's just too hard to inject into tumors in people, so we don't do it that way. And so who was I to know? I mean, I was only like 20, so it didn't really matter. But once I got into medical school and was studying, and we had this course on interventional radiology, and the interventional radiology guys were like, "Hey, we use the imaging and we stick needles and we biopsy tumors all over the place." I was like, "Wait a minute! If you stick needles in tumors and biopsy, then you could be injecting drugs, right?" And I talked with them. They're like, "Well, yeah, that's true." I said, "Well, that's what we need to start doing." So then I decided I shouldn't be an oncologist. I should be a radiologist because that gives me the capabilities of getting to the tumor and learning that. The oncologists are stuck with basically treating the patients with only intravenous and oral medications. And so that's the way I went, and then and of course did lots of cancer research and things like that, and got into a lot of ablative technologies where you stick needles into tumors and destroy parts of the cancer, and we use that to actually boost the immune response. And so there's lots of those type of things, and so now it's a combination together where you use ablative technology and you inject immunotherapies together to make the immune system attack the cancer.
Okay. And you know that so that is basically what we're doing here. Immunotherapy is using your own immune system to turn
Right.
around and fight the tumor that's growing in the person's body, correct?
That's correct. Yeah. Yeah. I mean, you're better off to get the person's own immune system to recognize and attack the cancer and get rid of it than to try to use other outside agents to kill cancer, which is obviously what we do with chemotherapy. And there are situations where maybe cancer is really big, you need to knock it down with some chemotherapy, but ultimately you want the immune system to be what gets rid of the cancer.
Okay. So, Dr. Williams, and let me ask you, is there specific type of cancers that utilize immunotherapy, or is this something that can be utilized with all cancers?
So technically, it could be used with all cancers. Certainly, all the solid cancers are very that for sure. When you get into some of the bloodborne cancers, that those cancers are actually of immune cells. That's a little more tricky, but still, you can actually in any situation. But yeah, the majority of cancers that we're talking about, we can get the immune system to see and recognize and attack those cancers.
Okay. So in your practice, is there a specific type of cancers that's prominent? There's more of this and that, that you see.
Yeah, well, so I personally see a lot of pancreas. I see a lot of breast. Those are probably our big cancers. And that's really one because like we've got good combinations of immunotherapies that work well for pancreatic cancer, breast cancer also as well, and and a lot of times the other patients, like with lung cancers or things like that, they have other options. So they don't necessarily make it to us. They can do various things. And so that, we don't see that as often. But, I'd say breast, pancreas. Obviously, we see a lot of metastatic colorectals as well. And that's a challenging case because those are normally not very immunogenic cancers. And you have to try to help make them immunogenic to get the immune system to see those. But yeah, really all cancers. I mean, sarcomas, all of them, they're all possible to get the immune system to see it. You just got to get the right drugs, into the tumor. It's not saying that you don't have to do systemic therapy. You could, and like right now, what I'm telling patients is that look, if they say do this chemotherapy, okay, do it, and we'll jump on top of it. Let's inject your tumor. You know, you do the chemo, but then we're going to inject it and then we're going to make it better. I mean, that's sort of a compromise. So we're not saying don't do that, do our stuff. No, let's work together and do it
Okay.
all together.
Okay. So you get a little combination then, basically, huh?
That's right. Yeah. And the thing is that when you go into the tumor, it's much more forgiving, right? Because like, the oncologist like, oh no, we can't give all these other drugs. Yeah, but you can because you're giving low doses in the tumor. That you can get by with, right? I couldn't give the drug systemically, then we start getting all these interactions. but I can give like lower doses in the tumor simultaneously while they're doing other therapies and improve those therapies. That's the direction that we're, going, is basically patient can do the standard of care, but let us go on top of it and make it better. So we call
Sure.
it standard of care plus.
Okay. Okay. So, one of the questions that pops into my mind, and maybe the listeners too, is this: as you're going through this type of treatment, walk us through a standard procedure of a immunotherapy patient, and then also is there side effects that they may be going through? Some of just the basic things that we can
Yeah.
expect.
Yeah, immunotherapy. So in general, and obviously there's lots of patients getting immunotherapies now. I mean, it's really common that any cancer patient is going to be given the chance to get Keytruda, Opdivo, something like that. And so, then usually get an intravenous. But yeah, there are issues where some of these can create these autoimmune problems, right? Where the immune system wants to attack part of your own body. And you can see it in the thyroid, you can see it in the skin, you can see it lungs, liver. It could attack anywhere, right? It can create any sort of autoimmune disease. Now, our personal experience, we do something that's a little bit different. That's not standard care, that should be, but it's unfortunate. We use the drug tocilizumab, which is an IL-6 blocker. That drug will actually
You speak in
reduce.
Spanish. Speak in
Uh,
Spanish now.
Sorry, yeah. Well, tocilizumab is an IL-6 blocker that normally would be used for some autoimmune diseases, right? But you give it to the patient initially, and it reduces their autoimmune issues from immunotherapy, and simultaneously, it actually makes the immunotherapy work better. And that's been shown in studies, but it's not standard of care because it doesn't have direct FDA approval for that. Tocilizumab has FDA approval for other things, and it's not for that. So unfortunately, if people are relying on trying to get their insurance to pay for it, that's not going to happen because it doesn't have that indication. That's the limitations.
Mm, always limited by some type of insurance, huh?
Yeah, the thing is that the insurance, all that restricts what you do. I mean, it's not, they're not letting you say, hey, you can have the best care or whatever. No, they're like really restricting the care significantly. And it would be nice if we could just say, hey, let us just do whatever's best, and you guys pay for whatever it is. Like, we're just going to do with, I mean, in the end, we'll save you money because like you're not going to mess around doing a bunch of bad stuff. Let us just do the right things and pay for it. And in the end, it'll be cheaper.
Yeah. So walk us through, a procedure. If a person has, you talked about pancreatic, is that one of your common?
Pancreatic is definitely one that we treat a lot. We have certain immunotherapy combinations that we work with that are really successful in pancreatic cancer, which normally that's not the case. And so now obviously we have different immunotherapy combinations that we can use that are tailored for multiple cancer types. And we have clinical trials that are going on for certain cancers, like we're trying to advance this, right? That's the thing, is that we're not just like treating and saying, oh, you got to come to us and that's it. No, we're trying to get other people doing it. We want everybody to do this. We want to share this knowledge, and we have clinical trials for various things. So we definitely have our prostate trial that's kicking off. I think we're going to have some other cancer trials kicking off later this year. Multiple sites all across the country. So yeah, I mean, we're just trying to get this out there.
Okay. Okay. So you have trials and things that you're working on, but as far as your standard of care with immunotherapy, walk us through, a
Yeah.
procedure and how that works. If I was a patient coming to you and I had what cancer, and tell me what would that be like?
Yeah, I mean, so let's say you take a patient who has advanced breast cancer. So they have, lesions in the liver or bone. They're giving them all sorts of different, therapies for that. We could take that patient and then we could come on top of it, bring them and treat them and inject into their tumors, do some pulse electric field ablation if necessary, and boost that response targeting those lesions. And we usually do that about once every 3 weeks. And depends on the patient, but sometimes it takes three, sometimes it takes six times, but we're able to help significantly improve the overall therapy, reduce the amount of treatment that the patient needs, and get them better, quicker, faster. I mean, this is the best way, you know. So that's a typical type of patient. So they can still and they can still keep doing their care, right? And then they can just jump on and they'll like in between while they're doing their treatment, then we'll put ours on top of it.
Okay. So it gives me an idea here. So you're talking about once every 3 weeks, and
Yeah,
depending on the patient, you really don't know how many treatments that person is going to need until you get going. Is that kind of how that works?
that's correct. I mean, so sometimes you're lucky, the immune response is really intense and one treatment does it. In some patients, two, three, occasionally six. Every now and then you get some that are nine, 12. I mean, that's, starts getting more unusual. But, most patients fall somewhere between three to six for those cases. To be able
Okay.
to get, for us to try to get the patient to what we call no evidence of disease. So that we've eliminated visible cancer and now we're just surveillance and watch, and then we'll see what happens long term. Hopefully, I think we have good techniques now to try to even prevent recurrence and things like that. But and clearly we need more and more studies and follow these people out for years to determine cures. But that's what our goal is, to get to cures, right? And
Sure.
that's what we are doing it. And but we would need to show it, and we'll need to show it more, and we need time. A lot of it just takes time because you really need 5 years of being cancer free to declare that you're cured. So we have patients who are now beyond 5 years from, but with older techniques. Now the newer techniques, come along, but those patients now we have to wait the time and let them go through and show. And then once they reach their 5 years, then we can say, okay, yeah, these patients are declared cured. And at that point, we can say it.
Okay. Well, I'll tell you, this seems like an advanced technology here. We're talking about going directly into the tumor. It's
Yeah.
it's one every 3 weeks. I mean, so when you say one every 3 weeks and you're going directly into the tumor, we're talking from a surgical procedure then, right?
Well, like, yeah. So the thing is that, most cancer patients have to have a biopsy, right? So somebody's sticking a needle in there at some point. That's your first chance of treatment. This is where we make our mistake. This is the mistake that we're making all across medicine. We should not be sticking the needle in the tumor unless we're already going to inject some medication into it. That's what we should be doing. Now, I don't know how we work this out, but that's what needs to be the standard of care, that we should not biopsy and then just leave it alone, wait a few weeks for results and all that stuff. No, look, we know from imaging, most likely that's cancer. There are medications that would be relatively harmless and inexpensive that we could inject to improve that cancer right from the biopsy. And we should be doing that.
So, Dr. Williams, tell tell us why you say we shouldn't be biopsying the tumor. I mean, that's a good question, right? What why not?
Well, the problem is, I mean, obviously you need a diagnosis. So you're going to need, at some point, you're going to need to address it and stick a needle in it. But you should not be biopsying it and not treating. That's the mistake. Biopsy is okay, but if you're going to biopsy, inject something into it. Inject things. I mean, we know that if you biopsy a tumor and you inject local anesthetic like lidocaine, or you inject non-steroidal anti-inflammatory drugs like ketorolac, that these are readily available. They cost you a few dollars, right? Um, that will significantly reduce the chance of that cancer spreading at the time of biopsy. But this is not standard of care. But this is what should be standard of care. And so hopefully that will change. It's easy enough just to add a few little things to it and say, look, anytime you biopsy a cancer, inject a little ketorolac, inject, lidocaine, inject the flu vaccine. If you inject the flu vaccine into the cancer, you're actually boosting immune response there, because I mean these things have been shown. So anything that you can put in there that makes the immune system want to see it, or to kill the cancer, would be better than to just biopsy it and do nothing.
Is
So
is there a detrimental effect to doing that versus
Well, so
injecting it with
when
something that help us
yeah,
out
when
with
you
this?
yeah, so when you biopsy the tumor, you do inflame it, and so there is an evidence that at that moment there could be increased chance of spread. Now, they don't, nobody wants to discuss this because, we don't want to scare people from getting biopsies, right? I mean, they need to get biopsies. It just needs to be done the right way. And so it's not that the biopsy's wrong, the biopsy just needs to be done the right way. And, but yeah, I mean, they know that from the time of biopsy, the longer you wait, the increased metastatic potential. And also we know, like, for example, prostate cancers now. Um, Before they were aggressively boxing people with like PSAs, 10 or whatever. But they found that that made the patients kind of worse because you put them on a path of aggressive treatment faster. Whereas if you just let it wait and let the PSA go when it got above 20, that's now they're saying, okay, then we should do it. So it means that the cancer, you shouldn't mess with it for a little while. You're going to buy a lot of time just letting it sort of smolder a little bit before it becomes aggressive. Because once you start poking it, um, things might take off at that point.
Mm,
Yeah, because it creates an inflammatory response that can be pro-metastatic for one thing. I mean, cancer will ultimately can and will spread, right? But when you biopsy it, you might accelerate that process.
okay. So talk to us a little bit about your success rate and what you've been. I mean, obviously, this is what you do, an
Right.
interventional, right? Interventional, right? You're looking at it through X-ray. Is that correct?
Yeah, so we use imaging mostly, CT, ultrasound, those type of things to see the cancers and go after them. And yeah, and so and one of the things I'd say is that we have our published data. So like on prostate, right? So we published that the ACR. Our company is Synchromune is our biotech that we work with. That's a certain group, and that data is out there. 87% objective response rate in stage 4 metastatic castrate-resistant prostate cancer. That gives you an idea. There will be other data that will be coming out later. And we're getting actually next week, Society of Interventional Oncology. We're gonna do our stuff on hepatocellular carcinoma. We've got really good, great data on that. Later, we're gonna do a big series on pancreatic cancer. We'll get some breast. We'll get all those, and we'll get the data out there. But the prostate gives you an idea of what the others can look like.
Okay. So this technology, this way or this approach, right? I would say this approach on how we treating interventional or using immunotherapy. You know, this has been around now. How long you been doing that, Dr. Williams?
Well, yeah. So I mean, I've been doing ablations and other stuff in human patients 25 plus years. Um, research wise, 30 something years. But yeah, obviously our things have gotten more advanced. We've got better understanding. It's been the past few years, I think it's escalated. And, originally people thought this idea was crazy. Now people are starting to understand that it makes sense. I think a lot of times it's funny when you listen to like the oncologists. I'll talk to them and say, "Hey, like we should inject some in the tumor." Like, what do you think that work? Or like, why wouldn't it? Like, how would you not address the tumor itself? Doesn't that make complete sense? I mean, that's the problem. So you should go after it.
Yeah. Well, I see. Well, one of the things we talked about here, and you people want to know where they find you, right? Where
Sure.
is the William Cancer Institutes, right? How
Yeah.
do people
Well,
find you?
yeah. So we have a website, williamscancerinstitute.com. You can find us on there. Our primary U.S. office is in Beverly Hills. So we do see patients there. I travel in now. So I work a lot like in drug development and research. So I see patients, but I don't do a ton of practice myself. I do have other doctors working with me. But yeah, patients can get us through there.
Yes. Wanted to make sure I put that out there so people know. In addition to treating immunotherapy, Dr. Williams, you also have a book out, right? The Immunotherapy Revolution. Talk to us a little bit about that book.
Yeah, this is a book I wrote years back. It's been out about 5 years, but it's sort of really just coming of age now because like people are seeing it and discussing, off-label drugs that people can use to enhance their cancer treatment, supplements that may help cancer treatment, things like that that we know weren't discussed. I'm also very heavy into the gut microbiome. The bacteria in your intestines are hugely important for your immune response, and that's something to address in cancer patients. There's a lot of data, and we have recommendations on that for patients of how to address it. So, it's overall to boost that cancer care to make it all better. And the book discussed all that. And of course, I've got a second book that will come out in the next year or two that will be more up to date. But that one is still very good. I mean, there's lots of things people don't realize that there's lots of off label medicines that you could use that boost cancer care. I mean, Viagra is anti-cancer. Several cholesterol medicines are anti-cancer. And there's various things that can enhance the responses, and people could easily get those drugs, but they're not aware of it.
Yeah. Yeah, and I think that's part of it, right, Dr. Williams? People's just not aware about how to go about it. When people get diagnosed, I mean, think about it. They're living their life prior to that, enjoying
Right.
whatever it is that they may have been doing, and all of a sudden you get a diagnosis, and then it's like, now what? It's
Yeah.
not like a common cold where you got to go to the store and get X, Y, and Z drugs to handle that. This is something completely foreign. So how do we bring about that awareness?
Yeah. Yeah. And the patients have, they need to take their care into their own hands. That's why I wrote the book, was wrote it kind of to reach out to the patients so they can understand the things that they need to do to protect themselves. Like interesting that, and this is not, it should be common knowledge, but it's not, that Tylenol, acetaminophen really impacts immunotherapy, makes it not work. And that's well published, yet most doctors are not aware of it. And a lot of doctors are giving patients Tylenol while they're on immunotherapy, and you should not. And obviously, patients with cancer have pain issues, and we need to find other options that are better. And there are other options that are better, to help patients with pain, but not giving them acetaminophen, which inhibits the immune response.
And that's a good cry, right? I mean, we know you got a headache or you feeling pain. These are some of the things that we did. What do you recommend when people are in pain that
Yeah.
will help out?
Well, ibuprofen and aspirin are definitely anti-cancer and safer. So if those are options for patients, that would be the way to go. The big thing is that patients, we know that narcotic pain medicines, one, a lot of them, because a lot of times patients are taking narcotic pain medications, they're mixed with Tylenol often. So that's part of the problem. The narcotics themselves can actually also inhibit the immune response, and you can counteract that with other medications. Like you can give the patient uh, naltrexone, which will block some of the negative effects of the narcotics, but still allows the patient to get pain relief. So there's lots of ways that you can handle the patient's pain in a better way. That will be, you want to try to do everything in an immune stimulating way, right? It's like, even from, if a patient's getting procedure or surgery, anesthesia, you want to look at what the anesthesia options are that would be less immune suppressive. And everything you do, you should be looking to try to boost the patient's immune response.
Yeah. Now, are these things the patients will find out on a consult with you, as far as
Yeah,
understanding? Because I mean, it's overwhelming and no one's going
a lot.
to, right?
It's a lot. Yeah, yeah. And so yeah, definitely, they could consult with us, and we would be happy to try to help out. And obviously, they should take a look at my book. That would give them a lot of insight as well. Our website, we have tons of information out there, trying to just get stuff out for people.
Yeah. Well, it's important, right? We appreciate anyone who's working towards helping someone fight during this journey. And Dr. Williams, we appreciate everything that you're doing right now, as far as being able to be a light and helping someone through probably one of the most scariest times of their life, right?
Yeah, yeah. Cancers. terrible disease, and we need to really be able to rid it for people, and so they don't have to worry about this. This is the thing is that, we want to make cancer where it's treatable. It's not going to be a big problem, right? Where you just go, you get it fixed, you don't have long-term consequences. That's what we really want for cancer care.
Sure, for sure. For those that are listening in, what could they expect? I mean, we talked a bit about side effects a little bit. I don't know if we touched it, but are they going to be able to go out and play sports or run around and do their daily activities after immunotreatment? What does it
Yeah.
look like for them?
So it's an interesting thing. So the immunotherapy is, of course, like a lot of times when the immune system is attacking the cancer, a patient feels real bad, right? But then as they get sort of over that, they start to get better, and then they actually get healthier. So it's really interesting, and that's one of the things that we're looking at. That we're finding that some of these immunotherapies were making the patients healthier overall. I mean, that's really unusual because normally the treatments make people sick, right? And this actually seems to go the other way. Certainly, there's fatigue and issues, but yeah, once you get kind of over that, then you're actually better.
And so talk to us. I mean, at one, you're touching in the immune system and you're making it, and you're talking about better health. But
Yeah.
what is the downtime, or what is the fatigue or the symptoms that
Yeah.
they can experience, and for what period of time?
So we find like patients with, like, if their cancer is like moderately advanced, right? That the first 6 8 weeks they'll feel a lot more fatigue, mainly that they'll be sleeping more, sleeping 10 12 hours a day. But they don't really feel that bad, right? I mean, it's just they're just a little more tired. I mean, but other than that, they're okay. It's not like they have other major issues. It's really just because the immune system wants to do its job and it needs you to rest.
Ah,
So you don't use all the energy.
for
It
sure.
gets.
Well, we live in a time period where people just don't have that luxury sometimes, right? To just sleep for 12 hours. So
Yeah.
for those that are, I mean, can you still work when you're getting
Oh
in
yeah, you can still
therapy?
work. Yeah, yeah.
Okay.
Patients still work. Yeah, this the one thing is this treatment I think is way better tolerated than the other standard like chemo and stuff. Obviously, this is in the future. We'll be able to make this very easy for patients. Of course, you catch people early before they have all the problems. I think it'd be very easy. I think the patients could be treated and almost experience nothing, but that's down the road once we get everything established.
Yeah. And give an idea. I mean, obviously everyone is different. How long of a treatment does it take? How long does it take to administer a treatment or to do an
Oh
immunotherapy?
yeah, yeah. So procedure, runs like about hour and a half. So yeah,
Okay.
yeah. And patients are under sedation, but not under general anesthesia. They're just sedated, or they're just asleep, but they don't remember anything. And so yeah, that's makes it easy, and it could generally is done outpatient for most people.
Okay. When you say kind of out, first thing I think of is like you get a colonoscopy, right? They
It's
kind of,
same the same. It's the same, right?
yeah,
Exactly. Yeah, yeah. Doing propofol, which yeah, which is like what you have with colonoscopy.
for sure.
Yeah.
Well, thank you so much, Dr. Williams. I wanted to make sure we cover a lot for the listener so they can walk away with something and some tools that they can utilize on this journey. We thank you so much for talking to us about your book. And we thank you so much for cutting out time of your day to come here on All Talk Oncology. We appreciate you. But before we let you go, is there anything before we let you go that you would like to say to those that are listening in?
No, I just think, for cancer patients, take charge of your own care. Don't accept just what your doctor says. Don't believe that your doctor knows what's best. Do your research, do your homework. It's your life. You've got to take control of it. And so, and obviously we're trying to give you the tools that you can do that.
Well, once again, thank you, Dr. Jason Williams, for joining us here on All Talk Oncology. It's a blessing. And for those that are listening, always remember, you're not alone in this. We're in this together. This is Kenny Perkins, AKA your cancer guy. And until again, I'm out.
So stay connected with us on All Talk Oncology Cancer Podcast. Make sure you subscribe to that right? Wherever you listen to your podcast, whether that's Apple, Spotify, make sure you subscribe and continue to spread that word, right? Engage in this because your engagement can help someone stay alive. And this is what we're talking about. So again, make sure you subscribe, hit that subscribe button. Again, this is Kenny Perkins, aka your cancer guy. Until again, I'm out.